Hello everybody, and welcome to my very first video in this channel. This is Reem Al-Gassim. I am an ophthalmology resident from PSMMC in Riyadh. For all my fellow ophthalmologists, today I'm going to walk you through something that surely at least one or two of your female family members have asked you about. That's right, I'm talking about Botox. You know, Botox is more than just cosmesis and wrinkle reduction, right? It has a much deeper and fascinating use in our field, especially in pediatric ophthalmology. So today we're going to highlight its uses, focusing mainly on strabismus. But before we get into that, let me give you a little intro. You know, Botox is the brand name, but the full name is botulinum toxin. Yes, this is how it's actually pronounced. This is a purified neurotoxin extracted from the bacterium Clostridium botulinum, which is a gram-positive, rod-shaped anaerobic bacterium. Now you should know that botulinum toxin actually has 7 main types, including type A, B, C, and down to type G. But type A is the most commonly used one, and it's actually the first to be extracted and purified. Commercially, we know it as Botox, and it's the oldest and most studied brand and the first to be approved by the FDA in the late 80s. However, other brands like Dysport and Xiomin are also available in the market, and they all use the same active ingredient as Botox, but they might have some differences in their formulations. Okay, so now that we know what Botox is, it's time to learn how it works. You see, Botox works through a process called chemodenervation. Basically, it's a chemical agent that blocks the nerve activity to relax muscles. To better understand this, a quick review of the physiology of the neuromuscular junction would help a lot. So please look at this picture. Above you see the nerve ending and below you see the muscle. And between them, we've got the neuromuscular junction. Inside the nerve ending, you see these tiny circles or vesicles, which are filled with a neurotransmitter called acetylcholine. Normally, when a nerve wants a muscle to move, it releases acetylcholine to the neuromuscular junction. Acetylcholine then binds to its receptors on the muscle and stimulates it to contract and move, okay? So this is what happens under normal condition. But when Botox enters the nerve ending, it blocks the release of acetylcholine to the neuromuscular junction. How exactly? Well, it breaks down a protein called SNAP25. This protein is needed to get those acetylcholine vesicles out of the nerve ending. So now without acetylcholine, the muscle cannot contract and is left paralyzed or weak. So to sum up, Botox is a bacterial toxin that paralyzes muscles. Why does this sound so dangerous? Well, that's because it is dangerous. Now picture this. If you were to ingest this toxin orally from food poisoning, its paralytic effects would be generalized, meaning that all of your body muscles would be paralyzed or weakened, and this includes the respiratory muscles. Now, just as you can imagine, the patient would have difficulty breathing and might wind up with respiratory failure and die. This is how botulinum toxin was originally known for. It was known for causing a potentially fatal foodborne paralytic disease called botulism, which was caused by the consumption of spoiled sausages during German war. Now this is not a joking matter, and even recently, if you recall, a local outbreak of botulism happened here in Riyadh 2 years ago, where there was 75 suspected cases, 50 confirmed, 20 intubated and required ICU admission, and one of them unfortunately died. So how are you gonna give this dangerous toxin as a treatment? Well, It all started in the 70s when an ophthalmologist named Dr. Alan Scott saw the therapeutic potential of this toxin, but only when it's given in a small controlled dose and as a local intramuscular injection. So he injected botulinum toxin in human extraocular muscles and proved its effectiveness for treating strabismus. And from there, the therapeutic applications of botulinum toxin have greatly expanded to include the treatment of various disorders of muscle hyperactivity, not only in ophthalmology, but also in neurology, ENT, and of course, dermatology and plastic surgery. Okay, now to address everybody's biggest concern when it comes to any drug, the safety profile. How safe is Botox? Well, after more than 30 years of testing and using and monitoring, Botox has been proven to be very safe and effective for both medical and cosmetic use. And what makes it exceptionally safe are four main factors. First, we use it in its purified form, meaning that we literally strip it out of any other harmful bacterial components before we use it. Second, we use it in an extremely small dose compared to the toxic amounts that would actually cause botulism. Third, we use it as a local intramuscular injection, so the paralytic effect would only involve a specific muscle. Finally, and most importantly, its action is temporary, lasting only for 3 months, maybe 4 months max. And that's because the nerve endings will gradually regenerate and the muscle will regain its normal function once again. So even if it's caused any side effects, it will be completely reversible. Okay, moving to the actual bulk of this lecture. How exactly is Botox injection used to treat strabismus? Okay, so just as you know, when you inject Botox into an overactive extraocular muscle, it relaxes and lengthens, while its antagonist contracts and shortens, and this brings the eye to a more central or orthotropic position. We call that pharmacologic muscle recession. It's just like surgically recessing the muscle, but without actually cutting it. Okay, but if you think about it, didn't we just say that Botox is only temporary? So technically speaking, after 3 months or so, wouldn't the eyes deviate again after Botox effects wear off? Well, the catch here is that this short-term paralysis gives the eyes a second chance to reset their alignment. How exactly? By activating the brain's fusion mechanism. So now that the eyes are straight, the brain can learn how to fuse images from both eyes, and eventually binocular single vision will be restored. We call this neural adaptation. This is especially true in children as their visual system is still plastic and can adapt and relearn easily. And from this, we can conclude that just like in surgery, binocular fusion is what stabilizes ocular alignment in the long term, and not Botox itself. Okay, but that's not the whole story. There is also a mechanical component. Remember, muscles are not static, so when they stay in a certain position for a long time, we'd expect them to undergo some structural changes. So while the injected muscle is paralyzed, its antagonist is constantly contracting to hold the eye straight, and over time, the antagonist muscle shortens and develops mild contracture, and the paralyzed muscle stretches and lengthens. We call this mechanical adaptation, in which there will be remodeling of muscle length to help maintain ocular alignment. Hope this makes sense. Okay, moving on. Here we've got a simplified timeline of Botox effect. Okay, so right after you inject Botox into the extraocular muscle, you will not notice any immediate change. And that's because Botox usually takes around 2 to 4 days to start working. At 1 to 2 weeks post-injection, this is where Botox effect peaks. So you'd see the injected muscle at its weakest, and the change in ocular alignment would be most noticeable at this point. In some cases, we may even see temporary overcorrection. Just like when you see a patient with esotropia becoming temporarily exotropic after Botox. So after this, the effect of Botox remains relatively stable for the next 2 to 3 months. This period is really important because this is when the visual system is allowed time to adapt and learn to fuse, provided that the patient has any fusion potential in the first place. Okay, so at 3 to 4 months post-injection, Botox effect start to wear off and the eye might start drifting again depending on how much adaptation has occurred. And by about 4 to 6 months post-injection, the muscle would have fully recovered its function. And this is when you can truly judge if Botox injection has achieved satisfactory results or not. Okay, moving on to the indications. You can't just offer Botox for every patient with strabismus. You have to select your patients carefully. You see, according to the AAO, clinical trials have shown that Botox injection is most effective in certain conditions, which include any small to moderate angle ESO or exotropia of less than 40 prism diopters. But whenever the angle exceeds 40, Botox can only be used as an adjunctive to surgery and it shouldn't be used alone, especially in infantile strabismus, because these patients don't have that much of a fusion potential. Also, we can use it to fine-tune any post-op residual or consecutive strabismus, especially if it's only a small angle. You would feel that reoperation is just not worth it. However, put in mind that you should wait at least 2 to 8 weeks after surgery before you attempt Botox injection to allow time for healing and stabilization of ocular alignment. In addition, we can also use Botox in acute paralytic strabismus, especially in sixth nerve palsy, where the lateral rectus is weak and the medial rectus becomes short and tight over time because it's contracting constantly. So here, we inject Botox into the medial rectus to balance out the horizontal forces on the globe. This way, we can prevent secondary contracture and also relieve any associated diplopia while the nerve is recovering. Also, in thyroid eye disease, patients might have restrictive strabismus with fibrosis of the inferior rectus or the medial rectus, and you know that during the active disease, we cannot do definitive strabismus surgery. So what we can do instead is to use Botox as a bridging therapy to provide temporary relief of diplopia and improve ocular alignment until the active inflammation subsides, and then we can plan surgery. That being said, you should know that Botox doesn't work in fibrous muscles. So your goal here is to inject the antagonist muscle to balance out the forces on the globe. For example, in inferior rectus restriction with hypotropia, inject the superior rectus and so on. Another use for Botox is in inflamed eyes. For example, in severe exposure keratitis due to lagophthalmus or facial nerve palsy, or in severe neurotrophic keratitis, you can actually inject Botox into the levator muscle to induce protective ptosis to give the cornea enough time to heal. This is called Botox-induced tarsorrhaphy. The same goes for prethysical eyes, which are basically atrophied, blind, and painful. So you can give a retropulbar Botox injection as a palliative measure to paralyze the ciliary ganglion. This will reduce ciliary spasm and relieve pain. Finally, Botox can be used as an alternative for surgery in patients who were operated on multiple times and are at risk of anterior segment ischemia. Botox can also be used as a predictive or diagnostic tool. It can determine the risk of post-op diplopia because, it's temporary. So we will see if the patient can actually tolerate straight eyes before we commit to surgery. In a similar way, we can also assess if a patient with a constant manifest squint possesses any fusion potential before surgery, because as we said earlier, fusion is what stabilizes ocular alignment in the long term. This way, we can know if the patient would actually benefit from surgery or not. Now, let's look at it from the other side. When is Botox not effective and should not be attempted? First of all, as we said earlier, Botox alone is not enough for large deviations, but you can use it as an adjunct to surgery. Again, Botox doesn't work well in restrictive or mechanical strabismus, like in trauma cases or chronic thyroid eye disease. Why? Well, because here the problem is not muscle overactivity, it's fibrosis and scarring. The muscle is physically stuck or shortened, so even if you paralyze it with Botox, the eye still can't move freely unless you release this restriction surgically. Also, Botox will not help in chronic, long-standing paralytic strabismus because the paralyzed muscle is already atrophic and has lost its function, and its antagonist muscle has already developed fixed contracture from the unopposed action. So surgery is the only option here. Another no-no for Botox is pattern strabismus and DVD because these are just too complex as they involve multiple muscles or abnormal innervation patterns. Finally, Botox won't work if the strabismus is secondary to over-resection or over-recession or muscle slippage. And you really don't have to overthink this. If a medial rectus has slipped backward after surgery, no amount of Botox can pull it forward. You'll need to surgically explore and reattach it. All right, now it's time for a very practical question. When to consider giving a repeat injection? Well, after the first injection, we usually observe the patient for at least 3 months, sometimes up to 6 months, to make sure the toxin's effect has worn off and the alignment has stabilized. If after this period the deviation recurs or undercorrects, then you can go ahead and repeat the injection. If after 2 to 3 injections the patient still doesn't achieve a stable alignment, then there is where you ditch Botox and start planning for surgical correction. Because honestly, if it hasn't worked after 3 injections, then it's probably not gonna. Okay, but how do we actually prepare Botox before we inject it? Botox comes in a dried powdered form, so you'll have to mix it with normal saline to turn it into an injectable solution. So what you do here is that you take a syringe and aspirate 1 ml from a preservative-free normal saline. Then you're gonna inject that into the Botox vial, which contains 100 units of the toxin powder. This way you're gonna have a final concentration of 10 units per 0.1 ml. Now you can use an insulin needle to draw the dose that you need straight from the bottle. Now that leads us to a very important point, which is dosing. You see, unfortunately, there is no consensus regarding what doses to administer, but generally, the typical dose of Botox ranges from 2.5 to 7.5 units. The exact dose that you give really depends on many factors, like the patient's age, the type of strabismus, and most importantly, the angle of deviation. If it's smaller than 20, you can give 2.5 units. If it's larger than 30, you can give 7.5 units. If it's between 20 and 30, you can give 5 units. So basically, the larger the deviation, the higher the dose. This is just a simplified way to think about it, but nothing is standardized yet. Now, when it comes to technique, the key point is how accurate you place your needle. because you want to get it inside the belly of your target muscle while minimizing diffusion to the adjacent muscles. To do that, we have three approaches. You can do it with direct visualization of the muscle, and here you would start as if you're starting a strabismus surgery. So you would open the conjunctiva, expose the bare sclera, and hook the target muscle. So now that you have a direct view of your target muscle, you're gonna inject Botox right into its belly. This approach is very safe, but the problem with it is that you risk fibrosis every time you expose and hook a muscle. Another approach is to do it under guidance of electromyography. This technique is mostly used in adults who are cooperative and awake. Basically, the Botox syringe will be hooked to a fine needle electrode that records EMG activity. So, as you advance the needle through the conjunctiva, it will make a sound that gets louder as you get closer to the muscle belly. It's very precise because EMG confirms muscle entry. However, this device might not be available everywhere. Lastly, the blind approach is the most commonly used one, especially by the experienced hands. As the name indicates, you're not going to see the muscle, but you're going to depend mainly on your knowledge of anatomy to inject Botox into the expected muscle area. So here, for example, if you were to inject the medial rectus, you would use a Moody to position the globe laterally and expose the nasal side, exactly 5.5 millimeters away from the limbus. You will find the insertion point of the medial rectus. Here, you would try to cross the muscle belly with a toothed forceps. If the globe moves with you, it means you are doing a great job so far. Now, with the other hand, you're going to advance the needle bevel up through the conjunctiva and along the muscle pathway, keeping the needle parallel to the scleral surface. This is very important to avoid globe perforation. Once you feel resistance, congrats, you're probably inside the muscle belly now, or at least within the muscle sheath. So you can go ahead and inject Botox slowly. However, if you notice ballooning of the conjunctiva as you inject, it means that you just gave Botox as a subconjunctival rather than an intramuscular injection. This is not ideal, but it's still better and safer than advancing the needle too far and risking scleral perforation, because you can argue that Botox is going to reach the medial rectus through diffusion anyway, even if it's given subconjunctivally. To minimize diffusion to other adjacent muscles, we usually instruct the patient to keep their head upright, sleep on two pillows, and avoid rubbing the eye for at least 24 hours post-injection. Okay, moving on to the complications. Most of the adverse effects of Botox are coming from toxin diffusion and inadvertent weakening of the adjacent muscles. These are mostly transient and resolve spontaneously once the effect of Botox wears off. Transient ptosis is by far the most common one. It just means that Botox has spread to the levator muscle. In a similar way, if a bit of Botox diffuses the superior or inferior rectus, patients can get a temporary vertical deviation. And when it goes to the orbicularis, it can cause temporary lagophthalmos and dry eyes. Also, after 1 to 2 weeks, when Botox reaches its maximum effect, you would notice some degree of overcorrection. Just like what you see in this picture, a previously esotropic patient shows up now with exotropia and ptosis. In addition, with the new ocular alignment, patients are expected to experience diplopia. In children, this is actually a good sign. It means the brain is trying to fuse images again and again. It's just temporary, and the kids usually tolerate it well. Another minor side effect is subconjunctival hemorrhage at the injection site, which will resolve on its own. The bottom line here is that you understand how important it is to inform the patients and their parents about these side effects and reassure them that they will all go away so that they know what to expect. Now, luckily, the more serious complications are very rare, and they include retropulpar hemorrhage or scleral perforation from improper injection technique, or transient pupillary dilation. This one is rather interesting. It occurs due to direct trauma to the ciliary ganglion, or intraconal diffusion of Botox to the ciliary ganglion, or intraocular diffusion affecting the pupillary sphincter. It's harmless, but the patient might complain of mild photophobia or blurred near vision for a few weeks. As you know, Botox is really safe, so it only has a few contraindications, including being pregnant or lactating, having myasthenia gravis or any other disorder of a neuromuscular junction, or having a local infection at the injection site. Okay, I have finally reached the end of my presentation. These are my references. Thank you all for watching my video. Please comment down below what topic you want me to explain next, and make sure to subscribe to my channel to get more videos like this.